Good evening, everyone, and thank you for being here. My name is Bianca Maree Harrington. I'm an IBS specialist dietitian and the lead microbiome coach for Microba. I'm here tonight with my colleague Leanne, who you'll get to hear from in a moment. I would like to give you an overview. Oh, sorry, it's not going to the next slide. There you go. I would like to give you an overview of what we will be covering tonight before I hand over to Leanne, who will be diving into our content. So tonight there are some dietitians on the line tonight who are new to Microba. So we will be providing a quick overview about our company, Microba, as well as the technology behind our Insight product, which allows us to profile all of the bacteria in the gut microbiome, as well as their functions, which we refer to as metabolites. I will be providing a demonstration of our Insight report, as I know that there are some of you on the line tonight who have not yet accessed this in your practice. So it will be great for you to see an overview of what this report entails. We will be going through this in a deeper dive in the case study presentation, which is webinar 2. So you will get more of an opportunity to go through each of the key features in our second case study presentation. And finally, the bulk of our presentation tonight will be based on some of the common gastrointestinal symptoms that your patient may present with you in practice. So we're looking at diarrhea, bloating, constipation, and inflammation, as well as looking at 2 inflammatory-based conditions, Crohn's disease, as well as colorectal cancer. So without further ado, I would like to hand it over to Leanne, who will get started by diving into an overview of Microba, our company.
Thanks, Bianca, and welcome to everyone who's joining us tonight. So as Bianca mentioned, I'm one of the microbiome coaches here at Microba as well, and I'm also an APD. I'm currently in the middle and the craziness of doing a PhD looking at the gut microbiome and the gut-brain connection in autism. So I have a lot of interest in the connection that those metabolites might be having on our mental health and behaviour and conditions in the brain. So as Bianca highlighted, I'm just going to quickly do a bit of an overview on Microba and the Microba Insight report for those who are new to this product and this process. So Microba really is getting, Microba's vision really is to make research quality microbiome analysis more readily available to the public, and that's sort of spurred on the development of the Microba Insight report. So on the screen there, we can see the Microba kit. That's what comes out to clients. So it's an in-home sampling test with all the instructions included, and then they send that back, and then they'll get their analysis and their results through their portal online. And as a practitioner, if you've referred anyone to have this test done, you'll also get those results through your practitioner portal. So Microba is the only company in Australia that currently provides this level of comprehensive microbiome analysis, and that's largely because of the research and the technology that we use. So the technology and the research that Microba is based upon was developed out of the University of Queensland by Professor Jean Tyson and Professor Philip Hugenholtz, and it's really been made possible with the advancements in computing power over the last decade. So what is this process? It's called metagenomic DNA sequencing, and it really allows us to get a clearer picture of all the microorganisms in a person's sample or in someone's microbiome. And as compared to, I guess, the most common process currently, which is 16S ribosomal RNA gene sequencing. So with the metagenomic DNA sequencing, we're able to detect all species with a relative abundance above 0.05%, and it's much higher resolution, so we're able to get down to the species or strain level identification, whereas the 16S gene sequencing really is only accurate to the genus level, or that grouping of bacteria, and within a genus there can be hundreds of species that have separate processes and separate metabolites, so they could have different impacts. With the metagenomic DNA sequencing, we can also identify new or previously unknown species. And since Microba has been doing this analysis, so over the last 12 months or just over that period, we've identified around 600 species that were previously unspecified or newly discovered. In 16S gene sequencing, they have to be able to match the genetic information in the sample to a known database. They can only identify currently known species. But I guess the biggest thing that's beneficial for clinicians and especially for us as dietitians is that metagenomic DNA sequencing allows us to report on the functional potential of the microbiome. And this is really emerging as a key thing around how the microbiome might be impacting health and disease. So our microbiomes have the ability, or the bacteria of our microbiomes have the ability to produce metabolites. Those metabolites have functional roles, and many of these metabolites are influenced by diet, and in turn diet can influence many of these metabolites. So let's just talk a bit to what we know about the gut microbiome and diet, and really the role for dietitians in this space. So as dietitians, we use evidence-based practice every day. We use the medical nutrition therapy as a way of educating and motivating our clients towards making changes that are beneficial for their health, and we use that to sort of structure the nutritional intervention that we want to deliver with them. So microbiome testing using metagenomics actually really enforces what we do. So a lot of the messages that come out of what we're seeing from their results are very similar or align directly with the things that dietitians try to deliver every day. So it can really just provide us with more oomph, more motivation and more evidence. So it's like the next layer of our medical nutrition therapy, but it can also help to further individualize nutritional therapies. So based on some of the metabolites or some of the results, there can be quite individualized actions that need to be taken. So we know that diet is quite influential to the microbiome composition and metabolite production, and we really see that it's the most modifiable factor in a mature microbiome. So it really speaks to this being our space to help get the best or optimize the potential out of a person's microbiome. A diverse microbiome that's fiber fueled is also associated with better health. So again, this is a role for dietitians to help clients understand how to get that diverse amount of fiber in and what is fiber and where are we getting it from. So that general level of education, but also using our expertise to really personalize that for people who might struggle getting those fiber requirements in alongside GI symptoms, which I guess is what we're talking to today. And then lastly, you know, these metabolites, again, we keep coming back to these metabolites being really important because they do have these functional roles, and we're seeing that not only do they interact locally and have local impacts on our health and functioning, so the GI area, but also these systemic effects. So being able to optimize someone's microbiome potential can help with sort of downward or on-flow effects for their health in general. So let's now talk about the metabolites. So as I mentioned, they are influenced very much by our diet. So there's two main fuel sources that reach the gut microbiome as a food source for these microbes. So one is fiber and one is excess protein that we don't absorb higher up. So when bacteria are using fiber as a fuel source, the metabolites they produce are beneficial short-chain fatty acids. And the main ones are acetate, butyrate and propionate. So the butyrate's used it's used locally only, really within the intestinal tract. It's a fuel source for the colonic cells. It helps keep that intestinal barrier function intact, and also helps keep down local GI inflammation. The acetate and the propionate is used locally, but can also go into portal circulation, where it has a role in regulating appetite and also balancing glucose or glucose homeostasis. When we have excess protein reaching the large intestine, the metabolites of the bacteria produced from feeding on protein sources can be mixed. So some can be beneficial and some can be pro-inflammatory. And these include the short-chain fatty acids I just spoke about, branched-chain amino acids, neurotransmitters, hydrogen sulfide, trimethylamine, among many others. So a couple of studies have looked at the impact of both plant and animal protein sources on the gut microbiome, and they suggest that the protein consumed is important, or the source of the protein is important. So in general, plant-based proteins have been shown to increase those short-chain fatty acids with that downstream effect of helping to maintain the gut barrier function and reduce inflammation. While consuming animal protein sources has been correlated with increased trimethylamine production, which is a metabolite that's associated with heart disease, and also reduced levels of short-chain fatty acids, which is a profile associated with inflammatory bowel disease. So the authors of the studies speculated that this is possibly because plant-based protein comes along with fibre, whereas animal-based protein is usually accompanied by fat. So this really means it's important that there's a good balance of fibre and protein-degrading microbes in someone's gut microbiome profile, and then we don't have an overabundance of those protein-degrading microbes, which could be more pro-inflammatory. And what we tend to see here as coaches is that people with GI issues tend to have a higher level of those protein degraders, and that could be due to long-term avoidance of grains or cereal products, removing gluten without finding appropriate alternatives, or long-term adherence to something like a low FODMAP diet, and all of those things impact fibre intake and then can result in increased protein degraders in the gut microbiome. So that was a very quick overview of how our microbiome works. I'm now going to hand you over to Bianca, who's going to run through a quick demonstration of the Microba Insight report.
Thanks, Leanne. So here's an example of a report that you will access as a practitioner on behalf of your patient. So every practitioner gets access to their practitioner portal, where their patient's results are located inside their practitioner portal. So here is our Microba Insight report. When we first jump in, what we see here is your patient's comparison to our healthy group controls. This is important as this is showing you how your patient is scoring relative to the healthy group, and that's actually how we report on all of our information. We have our diversity level, so looking at the diversity, the balance between how many different types of bacteria are there, as well as how evenly these bacteria are distributed. We have a look at what the gut microbiome is likely using as its main fuel source. As Leanne alluded to, protein and fibre are the two main fuel sources. And we can see here in this individual's report that they did have a high or elevated amount of protein degrading bacteria in their gut. We can also look at their top 5 species. So these are the bacteria that are populating their sample and are forming, I guess, the majority of what bacteria are influencing or have the most influence over that patient's health. We also have the key insights, and this is a great quick reference tool that you can use to see where your patient's results are different or they're displaying a difference to the healthy group control. So these are the insights that are outside of the average healthy range. Personally, as a practitioner myself, as well as Leanne, we do spend more time in this dig deeper section, as this is really where you're going to get the substance of the information, as there's a lot of detail contained in this section. So we can have a look at the microbial metabolites. So we report on 21 microbial metabolites. The majority of these are associated with good health. So we look at neuroendocrine potential, we look at short chain fatty acid potential, we also look at essential vitamin potential. There are the metabolites such as lipopolysaccharide, hydrogen sulfide, ammonia, trimethylamine that are associated with inflammation and can be indicators for poor health. And collectively, we group these together as the health indicators. You can also see an overview of all of the bacteria in someone's sample, and there are different filters that you can use to filter between the different views. So if you're interested in finding out all of the bacteria, there is an option for you to change the tab so that you can go through and look at every single species that is detected in someone's gut microbiome. Now, some quick reference tools that we have. So part of your patient's process of completing the Microba Insight test, they do fill in 5 questionnaires. One of those being being the mental health questionnaire, which is actually the depression, anxiety and stress scale, which we know as dietitians and any practitioners, this is the gold standard for measuring stress, anxiety and depression according to how someone is feeling in relation to their life within the last 7 days. And this is something that can be quite helpful as practitioners, as these conversations can be quite sensitive to have in nature. Perhaps your patient isn't comfortable with disclosing fully what is going on for them in their life. So this is a great reference for you to see if this is matching up with what they're reporting in practice. We also have the food frequency questionnaire, which is a nice comprehensive assessment of what their average daily intake is looking like over a 12-month period. And again, this just takes out the need for you to have a food diary or wait for a food diary to be kept, because we all know that compliance around food diaries can be quite mixed depending on the patient. The final thing that I wanted to share with you before handing back over to Leanne to dive into the common gastrointestinal symptoms is this sample composition. This here is where we are reporting on what percentage of the sample was coded for bacterial DNA, archaea, eukaryota, which are also the fungi that are found in the gut. Novel, these refer to newly discovered species of bacteria. And then we also have the elevated, the human DNA, which for some reason that's not showing up on this report, but that's okay. Sometimes you can see that this is elevated in the sample. I'll just jump back in and see if this wants to show us this time round. So we can see that this human DNA is elevated in this person's sample relative to the healthy group controls.
Okay, thanks Bianca for giving us that run through of the report, and hopefully that's useful for people who haven't seen the product yet. But now we're going to go into the clinical application around gastrointestinal symptoms. So as dietitians, we often do see people with gastro or GI issues, and they might come along with a diagnosis of IBS or irritable bowel syndrome or inflammatory bowel disease, or they may have no diagnosis. But we would always go through our standard ADIME assessment, but we'd be having a focus on the duration and the pattern of that symptomology, and any associated triggers that they might have identified themselves. With the dietary analysis, we'd be particularly looking for the fat and fibre, which obviously if you've done the test, there'd be that quick reference that Bianca just showed us, but also common bowel irritants they might be including in their diet. Looking to that stress and lifestyle factors, or the DAS results, to see how that's impacting on their, or potentially impacting on their GI symptoms. Also investigating what other tests they may have had. If they're avoiding gluten, have they had the celiac screening? Have they seen a gastro, and have they had any scopes done? Looking for those alarm features of the nocturnal voiding of the bowels, blood in the stool, or sudden onset over 50 years. So that's all standard stuff that we would do. But then you might be asking, so when do we use the gut microbiome testing? So look, I guess the first point to make is that microbiome analysis is not a diagnostic tool. It really is an informational tool. It provides us with another piece of our overall client's health picture, and lets us answer the question, could the microbiome be contributing to someone's health or otherwise? So it forms part of our overall assessment, and just like we see the client, no client or very few clients have, I guess, a perfect diet. In practice too, we very rarely see a perfect, if you could see me, I'm doing inverted commas, microbiome result. So there's always a chance to optimize their potential from their microbiome, and also to individualize it to get the best out of it. So for someone, or for 90% of people that are female, having 28 grams of fibre in a day might be sufficient to be getting good results for their microbiome, but there may be a section of people that when you look at their results, they're eating enough fibre, but that's not actually sufficient for them based on their microbiome results, or there's other metabolites flagging. So I guess what I'm trying to get to is that there's always room to improve. But I also understand, so from me, obviously I'm biased thinking everyone should be looking at their gut microbiome, it's my headspace, but I also understand that there's a cost to this and not everyone can afford to do it. So clinically in practice, when is it right, or when do you feel like it would be opportune to suggest microbiome testing to your clients? And particularly, obviously, we're focusing in this webinar on the GI space. So really, when someone has not responded to standard care. So for example, if you have someone with irritable bowel syndrome and they've been a non-responder to the low FODMAPs intervention, or their symptoms seem very sporadic and hard to pin down. So we can't really find clear triggers or directive causes from diet or even lifestyle stress-related triggers. Maybe someone with IBD who's having increasing flare-ups, and again, without you being able to really identify what might be behind that increased inflammation. Or it might be a person who has no diagnosis, and again, you're not able to really clearly identify their triggers for their GI symptoms. Another place this can be useful for dietitians is just as a motivational or evidence-based tool for clients. So you might be working with someone who's been long-term on a low FODMAPs diet, and you've been trying to encourage them to challenge, to liberate their diet for general nutrition, but particularly with the microbiome to get those fermentable fibres into tolerance levels. But they might be very reserved and worried because of symptoms and quality of life. So doing this test, normally what you would see would be that microbiome is quite starved because of that long-term adherence to low FODMAPs, and that may provide a motivation for your client to challenge and move forward with the diet. So let's now go into diarrhea as the first GI symptom we're going to cover. So there are a few bacterial species that do result in diarrhea as a symptom. So Campylobacteria and Salmonella are both bacteria that are associated with food poisoning. So it's quite an acute diarrhea. So I guess in practice, it would be rare that you'd have a client sitting in front of you with a history of diarrhea caused from these specific species. But in saying that, just the other week we had a lady who was reporting a history of diarrhea and did have Campylobacteria species present in her microbiome. So it is one to check, and obviously for her we sent her on to get further testing. Also, it's worth noting that people can be asymptomatic carriers of these bacteria. So if it's there in the report but they don't have the diarrhea symptom, then it wouldn't be a cause for concern or further testing. Also, Clostridium difficile is a bacteria that is an opportunistic pathogen, and it really seems to get hold post long-term antibiotics or broad-spectrum antibiotic use, and it results in fevers and diarrhea. So again, it's more of an acute known situation, but it is worth checking for that species. E. coli, by and large, is a commensal or normal bacteria that people can have in their gut microbiome. But so we report on the species, there are certain strains that are pathogenic and do produce a toxin, and the end result of that can be diarrhea symptoms. So if you had a patient who had high E. coli present compared to the healthy group, and you checked off all the other possible causes of diarrhea, they checked for parasites, you couldn't find clear dietary causes, stress didn't seem to be a factor, so you've gone through a complete check, then it could be worth sending them forward or having a discussion with them about getting diagnostic testing to see if they have any of these pathogenic E. coli in their gut microbiome. Also, a metabolite that we report on, a potential, is for Bacteroides fragilis toxin. So again, Bacteroides fragilis is a commensal bacteria normally found in the gut microbiome, but some of the strands produce a toxin. So this is a bit like E. coli, but in this instance, we're able to report on the potential for the production of that toxin. That toxin at high levels has been associated with intestinal inflammation and a precursor to colon cancer. So if, again, you would check that the diarrhea had no other known cause, and if they were presenting with the high potential for B. fragilis toxin, especially alongside maybe a sample composition that was showing high levels of a human DNA read, which could be indicative of inflammation, that could be a stronger case to send them forward for diagnostic testing. Research has also shown that diversity levels are linked to stool consistency. So there was a study done in 53 healthy controls, and that's this little diagram here on the slide. So along the bottom is stool consistency as per the Bristol stool chart. So from 1 to 6, so as we're going up, the stool is getting looser, and that's compared to the species richness or diversity. So as you can see, it's dipping down as the stool stool gets more loose or more towards diarrhea. So a lot of the research in this space is associative, so we don't know direction of these associations, but it would make sense that if someone is unable to hold their food, if things are transiting through their GI tract very quickly with diarrhea, then not only is that impacting on their nutrition, but also the bacteria having less exposure to those food sources, which could impact diversity levels. But the opposite way could be true, that diversity levels themselves could drive a downward or a downstream effect of diarrhea. But in any instance, diversity levels or low diversity levels within a report would be something we would be looking to put in some strategies to try and improve. So I went through sample composition. We'd always check that with GI, and we'd always check the DAS too, in terms of if their mental health or stress could be impacting on their symptomology. So with all of those together, with the rest of the overview on the report and your clinical assessment, we'd be able to move forward with potentially a more detailed intervention. So that could include diagnostic testing, so referrals or referrals to gastroenterologists if the human DNA read was high. It also could just provide further support for your nutritional intervention. So the person or the client in front of you might be someone who's just long-term had a low-fibre diet. They might be a young guy that's always eaten takeouts with high-fat, low-fibre, and they really just don't have enough soluble fibre to get enough bulk to their stool. So you'd be able to do this, if this test was something that you did as part of their assessment, you'd be able to check off, look, the microbiome might not be directly playing into this. Maybe their diversity levels are low because of their eating pattern, and it would be evidence for you to move forward and try and motivate that client to improve their fibre intake. Or it could be evidence to trial an elimination diet or a low FODMAPs diet. And you might be thinking about doing that in those elimination phases by supporting the microbiome with a fibre supplement or a probiotic. So moving on to constipation, so going to the other end of that scale, we're trying to look to whether the microbiome could be contributing to someone's constipation. We do know there's certain species that are methane producers, and methane has been shown to slow colonic transit, so has an impact on, ultimately constipation. So there's a connection between methane producers of the microbiome and constipation. So we don't at the moment have the facility in the Insight report to provide the potential for methane production as one of the metabolites. It is something that's in the pipeline, but at the moment what we can look to in the report is the species that produce methane. So the archaea as a group, which are very akin to bacteria, they're slightly different. We report on that level in the sample composition, but also if you did a list of the species that I think Bianca quickly showed us that too, that you can do a list of species in the report, and anything that starts with methano would be a methane producer. So we can have a look for those things in the results. Also, research has shown that people with constipation tend to have a higher proportion of the protein-degrading species in their microbiome. And again, association, so what's the direction? So it could be that, constipation is associated with maybe not enough fibre, then therefore they're not feeding enough of their fibre degraders and their protein degraders are getting a bit more dominant. Or it could be that the stool staying in the colon for a longer period of time, that interaction is causing some change to the microbial community. But again, just like diversity with diarrhea, a high proportion of protein degraders is something we'd always looked to try and improve from someone's report. And as always, we look at the DAS and the sample composition. So again, this helps you build a better picture, have a more complete picture for your client, and the plan going forward could include referrals if needed, or it could really just be supporting adjusting that fibre intake. So if they've got a high proportion of those protein degraders, we'd be looking to their fibre. Sometimes we see the fibre is maybe close to adequate or adequate, and then we need to really look at, is it diverse? So are they having enough fibre, or is the standard fibre intake of, say, 28 grams for a female, is that enough for this client? Do we maybe have to try and challenge that a bit more? Again, we could be looking at doing elimination of the low FODMAPs and thinking about supporting the constipation and moving the bowels with some fibre supplementation until things are moving better. So the last one I'm going to go through before handing you over to Bianca is bloating and flatulence. So I guess the key thing to think about here is where's the symptomology? Is the client reporting a high bloat or a bloating soon after eating? Because I guess in that instance, the gut microbiome testing is unlikely to provide additional insights directly on that symptom because of the location. Because obviously the gut microbiome, the testing we're doing is the stool, which is more indicative of the microbiome of the colon. So we're looking at the bacteria at that location and not higher up where the client is reporting symptoms. But again, as always, doing the test mightn't be lost because there could be a chance to optimize their overall microbiome health, and this could have flow-on effects for other areas and maybe even potentially some of their upper gastric stuff. It's hard to say, we don't understand all the connections. But if they're reporting the lower bloating and distension or discomfort lower in the bowel and or with high flatulence or a flatulence that has, you know, a particular odor, then it could be worth looking at this to see whether their gut microbiome is contributing to their symptomology. So we would look to these gas producers. So we've spoken through the methane producers, which would be producing gas and obviously could be related to distension or excess gas production. But interestingly, there's been some research that's shown actually in patients with irritable bowel syndrome that's diarrhea-based or mixed, they actually have less methanobacteria than the healthy controls and also less than people with constipation. So that's depicted in this diagram, the bar chart here. And the scientists or the researchers who did this research indicated that this actually, having not enough of these methanobacteria, could actually be behind excess abdominal gas in IBS, because methane producing or microorganisms actually are a major mechanism of hydrogen disposal in the colon. So if those methane bacteria aren't, or the methanobacteria aren't getting rid of that hydrogen, it's more available to be creating symptoms for the patient. So looking whether they're there or not can be interesting. Also, we report on the potential for the microbiome to produce hydrogen sulfide, which is a gas. And at excessive levels, hydrogen sulfide has been linked to decreasing the mucous membrane of the intestinal tract. Within normal levels, it's actually quite health promoting for the gut, but at that excessive level, it has been linked to things like inflammatory bowel disease. So the microbes that produce hydrogen sulfide do it through consuming foods that contain sulfur. So they're things like eggs, onion, garlic, Brussels sprouts, cabbage. So those foods that you always traditionally have associated, or people say that will give you bad gas, and it's because of that sulfur component. So that gives it that smell. So if you have someone who is reporting the symptomology of bad flatulence and they have this potential, this could be a point for intervention. And we would also look to their mental health scores as well. So when we're talking about intervening with the hydrogen sulfide, research has shown us that increasing fibre or diversifying fibre can actually reduce that hydrogen sulfide production from the gut microbiome. So that's sort of the first line strategy you use, because a lot of those sulfur containing foods are actually healthy foods. So we don't go to ripping those out of the diet, but there is room to consider the sulfur load. So I did have a lady who had odorous flatulence. She had a high potential hydrogen sulfide production from the microbiome, and she was also eating an omelette a day with onion in it and a side of sauerkraut. So that's really quite a high sulfur load. So we're able to manipulate that level, but also looked at her fibre in general. The other thing to think about with bloating, particularly around IBS, is that visceral hypersensitivity that people can experience. So research has shown us that people with IBS do feel that distension in the colon, or some subgroups within IBS do feel that distension in the colon they're more sensitive to that than healthy controls. So there's been some really horrible studies where they've blown balloons up people's backsides and seen that people who have IBS tend to register that discomfort a lot earlier, or that pain a lot earlier. So if you think that could be part of their symptomology, there's been some good evidence around gut-directed hypnotherapy and helping to reduce that abdominal pain sensation and bring down that sensitivity of the colon. So now I'm going to pass you back to Bianca, who's going to run through inflammation and some inflammatory-based IG conditions.
Thanks, Leanne. So I firstly wanted to preface this section by highlighting that there are estimated to be hundreds of species that are associated with inflammation. So focusing on species alone is not always going to give you the full picture of how the gut microbiome might be impacting or driving inflammation. This is why understanding metabolic potential by looking at some of the pro-inflammatory metabolites that I'm about to go through is useful, as it enables us to look at the collective potential of all of the bacteria found in the gut microbiome. So that being said, I have popped up some specific bacterial species here on the list, as these are ones that are found in the important species list on occasion as we go through reports. Personally, as coaches, Leanne and I probably find that the Agathella lenta and the Bilophila wadsworthia is a fairly common species that we see as we go through customers' reports with them. Clostridium Emboltiae is also one that we might see in individuals who have inflammatory bowel disease, which is something that I will go through now. So firstly, with Agathella lenta and Bilophila wadsworthia, these species are protein degrading bacteria. So usually if these species are elevated in the gut microbiome, it is usually an indication that this person is not getting adequate fiber in their diet. It could also potentially be too that they're just not getting enough diversity or variety in the foods that they eat, especially if they are habitual eaters and eat a lot of the same things every single day. The relationship with Clostridium Emboltiae is not as straightforward, as this particular species can use a variety of fuel sources. However, it is good to know from the research that this particular species is one that produces pro-inflammatory proteins and has been correlated with inflammatory bowel disease. Fusobacterium is a species that has its disease associations with colorectal cancer. So if this species is elevated in your patient's sample, and they might be at a higher risk of developing colorectal cancer, especially if they have other factors at play that are increasing their overall risk for developing colorectal cancer. So let's jump now into the metabolites, as this is really the substance of understanding how all of the bacteria in the gut microbiome might be impacting inflammation in your patient. So lipopolysaccharide is one of many pro-inflammatory metabolites I'm about to go through. It is a component of the cell walls of gram-negative bacteria. There are many structural variants of lipopolysaccharide. The structural variant that is linked to inflammation is the hexa derivative, so hexa LPS as we refer to it. Now, hexa LPS interacts with human immune cells, and how it is liberated is through saturated fat in the diet. So if you have someone who has this elevated lipopolysaccharide potential in their gut, it is beneficial to look into their diet to specifically look at, firstly, how much fat they're eating, which is something that you can do using our food frequency questionnaire results, but then you can dive deeper into the questionnaire results to look at what sources of fat they're eating in their diet. Are they getting predominantly saturated fat sources, or potentially they might be eating more of the mono and polyunsaturated fats, therefore that overall risk is lower, as this effect is more observed with saturated fat in the diet. The next metabolite is ammonia. So ammonia is associated with our protein degraders in the gut microbiome. We're specifically measuring for the enzyme urease, which is involved in the conversion of amino acids into ammonia. Now, ammonia starts to impair gut barrier function and also contributes to intestinal inflammation. And we know that maintaining that gut integrity is really important. Otherwise, it actually makes it easier for certain inflammatory substances to get out of the gut and into the body, where they can elicit an immune response. So when this is elevated in your patient's report, the key actually comes back to firstly increasing fiber, as we're wanting to promote the growth and activity of the beneficial fiber digesting species in the gut. So it could be increasing total fiber, and again, it could also come down to looking at diversifying the diet where possible to ensure that you're getting a nice variety of foods coming in. It can also be related to excessive protein in the diet, although when faced with the option, generally bacteria will go for fibre if there is sufficient fibre available. However, excess protein is not absorbed. All of it is not absorbed in the small intestine, so it can make its way down to the gut bacteria where they can ferment it and result in the production of some of these more pro-inflammatory metabolites. So you could have a look at how much protein your patient is consuming in the day, and you could also look at how they might be spacing that out as well. Perhaps they're lumping it all in one go, in one meal. So looking at ways that they can space that out throughout the day might also be a helpful strategy. Leanne has gone through hydrogen sulfide, so I don't want to spend too much time here as it will just be reiterating the key points. As mentioned, hydrogen sulfide does disrupt the gut mucus barrier, and especially in individuals who might be at a higher risk, this might predispose them to inflammatory bowel disease and other inflammatory conditions. So with the hydrogen sulfide, the answer is increasing fibre. The research is suggesting that that helps with inhibiting the production, but it could also come down to moderating the total sulfur load, especially if they are symptomatic with that rotten eggy flatulence. Now, finally, butyrate is the other potential that I wanted to address here tonight. Butyrate has an inverse relationship to inflammation. So what I mean by that is that a low butyrate potential is associated with inflammation. This is because butyrate is one of our key short-chain fatty acids that are produced by the gut microbiome. And as Leanne mentioned before, this does reduce inflammation by interacting directly with the colonic epithelial cells to help with suppressing inflammation. So if your patient is presenting to you with an array of these metabolites being elevated, and it's also accompanied by a low butyrate potential, you are wanting to work with them to increase butyrate production. And how we do that directly through diet is by increasing sources of resistant starch. Finally, the sample composition is also a quick reference tool that you can look for to see if there is any signs of elevated human DNA in the sample, which could indicate that inflammation is occurring, and that could be related to food intolerance-based reactions. It could also be an indication that there is increased mucus or blood in the stool. So it's an opportune time to talk to your patient about referring them on to a gastroenterologist if they have not yet gone through and had their gastroscopes complete. So I wanted to talk a little bit about the common inflammatory bowel conditions. So I'll be speaking about Crohn's tonight, and I'll also then be speaking about colorectal cancer. So it is important to know that the exact cause of IBD is still unclear, although it is thought that a combination of factors, including genetics, environment, and lifestyle choices, are involved. However, these factors do not completely explain IBD risk, and recent research is now indicating that changes to the gut microbiome may also play a role in the onset of IBD. So if we use this in this diagram that we have here, we have a healthy control versus someone who has Crohn's disease. We can see some significant differences, particularly when we're looking at diversity level. So we can see there's quite a significant reduction in the types of bacteria as well as overall numbers in someone who has the disease. When we're having a look at the intestinal barrier function, we can see here that the integrity has been compromised, and potentially this may be due to reduced short-chain fatty acid potentials. Specifically, butyrate and acetate are the two short-chain fatty acid potentials that are reduced in individuals with inflammatory bowel disease. We also see an increase in some of the more pro-inflammatory metabolites like lipopolysaccharide, and due to this increased permeability or the compromised integrity, we can see that it is a lot easier for these inflammatory molecules to pass through and interact with our human immune system cells. Sorry, I'll be 1 second. I don't know why that decided to open. Oh, goodness.
Technical issues.
Yeah, sorry guys, won't be 2 seconds. I'll just need to close that and share again. Oh, goodness. Sorry guys, won't be 2 seconds. Okay, now we'll just need to go back. All right. Share screen. Yeah, cool. Okay.
Sorry, everyone.
Sorry, everyone. Something that is also quite common with individuals who do have Crohn's disease, we also see that there is a reduced number of fiber degrading bacteria in the gut, which indicates that a low fiber intake potentially is a contributing factor to the development of inflammatory bowel disease. Now, with colorectal cancer, the research regarding the link between the gut microbiome and colorectal cancer is quite substantial. We know that various bacteria such as Klebsiella, Streptococcus, Escherichia, or E. coli, Peptostreptococcus, and Bolophila are commonly found in the stool as well as the mucous lining of individuals who do have colorectal cancer. Something that's also common, not across all of those bacteria that I just mentioned, but a lot of those are also oral microbes as well, which is something to keep in mind, that ideally these bacteria are not ones that we want to see in the gut microbiome. Overall, there is an increase in the protein and mucus degrading bacteria. They are elevated, which could also indicate too that there is a lack of fiber, and that is actually contributing to the developmental onset of colorectal cancer. So if we use this diagram as well, just to have a look at the relationship between the gut microbiome and some of the common trends between someone who has the condition, so this would be the side on the left versus someone on the right who does not have colorectal cancer. The diagram on the right shows that the tumor suppressive metabolite, so it gives you the example of butyrate, is able to interact with not only the human immune cells, but it can also interact directly with the colonic epithelial cells. The receptors on these cells, as well as the colonic epithelial cells, contribute to the protection against inflammation and carcinogenesis in the microbiome. So really, butyrate helps to suppress any inflammatory activity in the gut microbiome. So it is considered to be protective against the development of colorectal cancer. Whereas someone who does have colorectal cancer, we tend to see that more of these cancer-promoting metabolites, and I'll talk about LPS and its role in cancer in a moment, indicates that these pro-inflammatory metabolites, particularly when the integrity is also compromised, can interact not only with carcinogenic cells, but it can also elicit a response with our immune system cells. Now, something that is quite interesting, so hexa LPS, which is the inflammatory LPS, is active or can activate toll-like receptor 4 as well as gene receptor CD14, and both of these receptors are found on human colonic colon cells, which indicates that LPS may in fact be involved in the proliferation of colorectal cancer. So, in summary, from tonight's webinar, if your patient is suffering from any of these conditions that we've mentioned, or any condition in general where you suspect that the gut microbiome might be implicated and the decision has been made to take the Microba Insight test, the key is to work with your patient where appropriate to optimize their results. Dietitians are at an opportune position to carry out such therapies, as it takes a certain knowledge and skill set to support your patient in adjusting their diet and other lifestyle factors, particularly when you take into consideration pre-existing food intolerances, allergies, accessibility, financial limitations, and even just the skill set of your patient. These are all things that need to be considered when you're giving that personalized approach to patient care. Optimization is key. So yes, it is great to understand the metabolic potentials and identify species associated with specific disease states or conditions. However, as we've alluded to tonight, improving on any metabolic function that is out of range, whether that also be looking at diversity, so increasing their overall diversity, improving the digestion potential, this may result in positive health outcomes outstream. So it's not at a complete loss if your patient doesn't necessarily have any of those standout metabolites or species. There is always opportunity to make adjustments to someone's microbiome. It's also key to understand too when it is appropriate to test. So as we've alluded to in the webinar tonight, conventional management, this is possible when conventional management strategies are ineffective. Your patient's symptoms are variable and they don't seem to have any rhyme or reason. They're experiencing repeated flare-ups and you can't pinpoint what exactly these flare-ups are related to, or there's no definitive diagnosis for their complaint. And as mentioned, our second webinar will be on Wednesday, October the 23rd. We will be going through a specific IBS case study. So if you would like more details about that, please save the webinar date. And we will be in contact too as well with more information on how you can tune in. If you do have any specific questions, please email me. The email is down the bottom here, biancamaree.harrington@microba.com.